Good evening.
Yeah, so good evening, chiefs. Good evening, colleagues. Welcome again to another session. So today we are going to be looking at the pharmacology of antiarrhythmic drugs. For me personally, this is the most volatile aspect of pharmacology. But we have Dr. Awindago to take us through this discussion, and I'm sure it's going to help us remember the important things about antiarrhythmic drugs. So without much ado, Dr. Awindago, the floor is yours.
Thank you, Dr. Conte. Can I be heard?
If you can speak up a bit louder or get closer to your microphone.
All right. Is it better?
Yeah, that's better.
Okay. All right. So good evening, everyone. Good evening, chiefs. I will start with leading a discussion for pharmacology of antiarrhythmic drugs. So this evening, I'll try to see how best I can do that. So we'll look at the classifications, mechanisms, and some clinical applications. So these are medications that are used to treat abnormal heart rhythms, to restore normal heart rhythms and prevent arrhythmia-related complications, which are mostly sudden cardiac death and heart failure. And generally to treat symptoms and then to prevent deterioration of cardiac function. And then in some cases, tachycardia, irregular rhythms, and dysynchrony, especially in people who have very frequent ventricular ectopics. And then to also prevent the transformation of arrhythmias that have been tolerated into malignant ones. It's important to know that they have a very narrow therapeutic window, which means that the difference between the therapeutic doses and lethal doses is quite narrow. So a change in dose can usually lead to dire consequences or marked side effects. Also of note is that they have a high intersubject or individual variability. So the drug might work well in one individual at a certain dose, and then the next patient would work at another dose. So we should take that into account when we are treating patients. And then there are multiple factors that interfere with the drug effect. So race is one, gender, the genetics, temperature, drug-drug interactions, neurohormonal changes, disease states, so such as hepatic impairment, heart failure, can all affect the drug effects. The other thing to note is that some of these medications have multiple electrophysiological and pharmacological effects. Like amiodarone, we know, for instance, has effects in all the classes. And the effects would also depend on the route of administration and the active metabolites that they produce. So, like I mentioned earlier on, the ultimate goal is to restore normal rhythm and conduction. And how do these medications do that? Either they'll slow the conduction velocity, they would alter the excitability of the cardiac cells, or suppress the pacemaker activity. So these are the broad categories of the function of the antiarrhythmics that we have. To go on, we'll just recap the action potential of the cardiac muscle and the pacemaker cell. So if we all remember, generally there are 5 phases. Phase 4, which is the resting membrane potential, in which case we have open potassium rectifier channels, and these keep the transmembrane potential at -90 millivolts. Phase 0, we know whenever there is stimulation of the cardiac muscle, there's a rapid depolarization, and this occurs as a result of a rapid influx of sodium cells through open fast sodium channels into the intracellular space. And once this happens, the transmembrane potential rises from -90 to about minus 20, thereabout. Just after that, we have the transient potassium channels that open, and the potassium channels leave the intracellular space into the extracellular space. And that results in what we call the early repolarization phase. After that, we have a balance of calcium channels that are open, and then potassium channels that are also open, which flow in the bidirect. So calcium channels into the IC and potassium channels out into the space. So this keeps the membrane potential at a plateau, which is almost flat at about 0. Okay. Then we have the late repolarization phase, in which we have the calcium channels will close, and then the potassium channels and the transmembrane potential to -90. And until there is another wave of stimulation, then the action potential occurs again. We have a different situation in the pacemaker action potential phase. So because of its unique characteristic, it tends to go through a cyclical, spontaneous action potential. So the pacemaker has a slow depolarization on its own. It doesn't need to be stimulated. And this is because it has a slow influx of sodium and there's a decreased influx of potassium. So gradually, the transmembrane potential increases from -60 to about -40. And then that triggers a rapid influx of calcium to depolarize it. So in the pacemaker cells, we would note that depolarization as a result of calcium. And then in the cardiac myocyte cell is due to sodium influx. Okay, but this hasn't got a plateau phase. So it just goes up, and then there's outflux of potassium, and then there's repolarization back to baseline. And then we have the slow sodium influx, and then the decreased potassium influx, which repeats the cycle all over again. So the pacemaker action potential does not need any form of stimulation compared to the cardiac action potential. So the antiarrhythmics commonly are classed using the von Williams classification. In other texts, we'll see Singh von Williams classification, so SVW, or the VW classification system, and traditionally has classified antiarrhythmics based on their mode of action. And we have class 1, class 2, class 3, class 4. Other texts will add a class 5. Others will say other drugs, and these include adenosine, digoxin, atropine, magnesium, and ranolazine, and ibabradine. So class 1 antiarrhythmics generally broadly are sodium channel blockers. So they block phase 0 of the cardiac action potential. And then class 2, they have their effect on the autonomic nervous system. So mainly would affect the sinus and the atrioventricular nodes. Then class 3 is the potassium channel blockers, which amiodarone belongs to. They usually will prolong repolarization. That is phase 3. But like I mentioned, amiodarone in its own class has all class class effects from class 1 to class 4. And then class 4, we have the calcium channel blockers, so which also sort of affects the AV and the sinus nodes mostly. So I'll now look at, and then there's this classification that was proposed in 2000, which is known as the Sicilian gambit. And that seems to look at comprehensively at the antiarrhythmics. So that will look at the channels that are affected, the receptors that are affected, the pumps, the clinical effects, and the ECG effects. So the classification is based on these characteristics. It's quite complex, so hasn't really caught up in clinical practice, but that looks at classifying and providing some degree of clinical utility, but because of its complexity, it hasn't really caught up with clinical practice. So the Von Williams is still the commonly used classification for antiarrhythmics. So the class 1 sodium channel blockers are divided into 3 main types. That is a class 1A or type 1A, type 1B, and type 1C. Type 1, we have quinidine, prokinamide, and disopyramide. Quinidine is still used, but the prokinamide rarely used nowadays. So these antiarrhythmics, the class 1A, if we look at the graph, the diagram, mostly would affect the phase 0, and then they also affect phase 3 of the cardiac action potential. So what they tend to do is that they would prolong the action potential duration, and effectively they are prolonging the effective refractory period. So that is how they exert their effects. They do also have some effects, so they tend to have some negative inotropic effects. Type 2B, that's lidocaine, mexiletine, the common ones, usually would affect ventricular tissue. They have little effect on atrial tissue. So, and particularly ischemic ventricular myocytes is where they mostly would exert their greatest effect. And then we have type 1C or class 1C, which is flecainide and propafenone. And they seem to have the most potent sodium blocking effect and also have some negative inotropic effects. So if you look at the diagram, so the 1 would affect the rapid depolarization phase and then the repolarization phase. So what it does is that it extends or delays or prolongs the phase 3 of the cardiac action potential. And that sort of increases the duration of the action potential, which is usually equivalent to the QT interval. The class 1B that is shown here actually shortens the duration of the action potential. It would actually shorten the duration of the action potential. Whilst class 1C usually would not affect the duration of the action potential much. So class 2, these are the beta adrenergic blockers. And we all know about beta blockers. Mechanism of action is blockade of the cardiac beta-1 adrenergic receptors. And the way they act is that through the sympathetic nervous system. So the beta blockers would act in this region. So normally when there is beta adrenoceptor stimulation, the stimulation of the stimulatory G protein, which activates adenylate cyclase, which in turn causes the conversion of ATP to cyclic AMP. Okay, so once that is done, that also activates the protein kinase. That's a cyclic AMP dependent protein kinase, and that tends to cause opening of the calcium channel, allow influx of calcium into the cell, and this causes increased heart rate, increased contractility in the myocyte. But what happens? So when this is inhibited, is blocked, this G protein is not stimulated, and this activation does not occur. Okay, so in the end, you don't have influx of calcium into the cell to cause increased contractility and inotropy. So the clinical effects here, we have slow sinus rate because it tends to affect the sinus node. Because of its effect on the AV node, there's a prolonged AV conduction and also increase the refractiveness. And it inhibits automaticity, that is of the sinoatrial node. And then, like we said, blocks the cardiac sympathetic innervation. And then also circulatory catechol beams. Class 3, these are the calcium channel blockers. And we have sotalol, dofetilide, ibutilide, and amiodarone. So amiodarone is unique in that it has properties of all 4 classes. And we also have dronidarone, which is like amiodarone, but lacks the iodine moiety. So the side effects of amiodarone due to the presence of iodine, you don't have that in dronidarone. So, but it has similar electrophysiologic actions as dronidarone. So these block the calcium potassium channels, and so we know when the calcium potassium channels act here, that is a phase 3 of the cardiac action potential. So this is where they actually exert their effect, and tend to affect 2 calcium channels mainly, and that prolongs the action, the duration of the action potential, and also makes it refractory to stimulation. Class 4 is the calcium channel blockers. And basically, we have 2, verapamil and diltiazem. And these generally would block cardiac L-type calcium channels, which leads to decreased calcium in the cells, and would affect AV nodal conduction, increase refractoriness, and it's also known to have some mild reduction in automaticity of the cell. Okay, so later we can take a look at this table, but this table looks at the effect of the action potential, examples of the medication, additional class effects, major unique side effects, which are unique to these, and then common antiarrhythmic indications. So I'll go into detail with individually. So for the class 1A, we have quinidine, procainamide, and disopyramide. So quinidine blocks sodium channels. It also blocks the rapidly activating potassium channels, and then blocks the ITO potassium current also. So that is its main mechanism of action. This would lead to prolonged action potential duration. So the action potential of the cardiac myocyte is prolonged. But in addition to these effects,
so well and so hard.
Atropine-like action.
So, had that finish, and that's all she needed was just that last little burst.
So these, so it exhibits some anticholinergic effects, and this causes an increased conduction through the AV node, and this increases the risk of ventricular tachycardias. It also has alpha adrenergic blocking effects. And then on the ECG, mostly what you tend to see is a prolonged QT interval, a prolonged PR interval, and a widened QRS complex. And it's noted to also unmask latent Brugada because of its prolongation of the phase 3 of the action potential. So in patients who probably have received some quinidine for some other arrhythmia, you might see a Brugada type 1 or type 2 pattern in these people. And but this is usually transient. Once they are off the medication, the pattern also disappears. It can be given oral and IV, mostly indicated for atrial flutter, atrial fibrillation. And these are commonly used in the post-operative atrial flutter or atrial fibrillation, and in some cases to maintain sinus rhythm after cardioversion. The adverse drug reactions, it's what is known as quinidine syncope. And this is usually due to torsades, due to fainting episodes because of the torsades that occur in these patients. Usually will occur and terminate on its own. So patients tend to have syncopal attacks while they are on this quinidine. The anticholinergic effects usually lead to dry mouth, blurred vision, urinary retention, and then constipation. Because of the alpha adrenergic blocking effect, you also tend to have hypotension, which leads to, because of the decreased contractility, you tend to have hypotension as a result of the negative inotropic effect, and also because of the vasodilatory effect. And the quinidine on its own reduces the renal clearance of digoxin. So when given with digoxin, can lead to toxic levels of digoxin. Procainamide also has, like so the class effect is sodium channel blockade. So it also has a blockage of the rapidly activating potassium channel, in addition to blocking the sodium channel. Also prolongs the action potential, but is less anticholinergic or alpha blocking effects, mainly given IV and use in AF in pre-excitation syndromes, but it's more effective in ventricular than atrial tachycardia. So procainamide tends to be used in the ventricular tachycardias instead of atrial tachycardias. Adverse reaction commonly has a lupus-like syndrome. Lupus-like syndrome that is known with procainamide can also lead to hypotension due to decreased peripheral resistance. Toxidosis, we can have torsades, and then there's also known to cause hallucination and psychosis. Disopyramide also blocks sodium channel and then the rapidly activating potassium channels. Also prolongs the action potential duration, has anticholinergic effects, is given as oral, and mainly used in patients who have a high burden of ventricular premature contractions. In addition, it can cause, no, I think it should go up. So its use is also in bradycardia-induced atrial fibrillation, and also in patients who have HOCM and develop atrial fibrillation. It also, the bradycardia-induced AF and AF in HOCM should be under clinical uses, So because of its anticholinergic effects, patients also have the dry mouth, blurred vision, urinary retention, and some constipation. So class 2B, we look at lidocaine and mexiletine. Mexiletine is actually an oral analog of lidocaine. So these block sodium channels, and preferentially in the ischemic tissue. Like I mentioned earlier on, these shorten the action potential duration. So they shorten the action potential duration. So the rapid sodium channel binding kinetics used to what causes what is referred to as use dependency or frequency dependency effect. So this refers to a situation where, because it has a rapid binding and a rapid uncoupling, it tends to be very effective when the patient has high heart rate. So it is more effective if the heart is beating at a higher rate compared to if it's beating at a slower rate. So that is the use dependency or frequency dependency effect, and that is because of its rapid binding, sodium binding kinetics. Mexletin, on the other hand, is less anticholinergic and has less alpha blocking actions. Administration is usually by IV bolus or slow infusion, and it's not effective orally. That's lidocaine due to its bioavailability, just 3%. So we don't get oral formulations, but Mexletin comes as an oral formulation. So generally ventricular arrhythmias in myocardial infarction, symptomatic premature ventricular beats, but not effective in the atrial arrhythmias. That's lidocaine. Mexletin, ventricular arrhythmias, and then in digitalis-induced arrhythmias, it's quite effective. Adverse effects, CNS side effects, so dizziness can occur, some tremor, blurred vision also occurs in some individuals, and then they can progress to seizures, altered mental status, and coma, and particularly is if given in toxic doses. For Mexletin, similar side effects, tremor, drowsiness, but diplopia here, and also has some hypotensive effects. For class 1C, we look at flecainide and propafenone. So flecainide is known to block sodium channels that we know. It is also known to inhibit the calcium release from the cardiac sarcoplasmic reticulum. And that makes it so in patients who have the catecholaminergic polymorphic ventricular tachycardia, because of this effect, it can be used in those patients with some success. Propafenone, on the other hand, blocks voltage-gated calcium and potassium currents in addition to sodium channels. And these have no effect on the action potential. What you have is prolongation of the PR and QRS intervals with only a slight increase in the QT interval. So the increase in the QT or the duration of the action potential is not that significant. Also has negative inotropic effects, and also has a use-dependent effect. So can cause widening of the QRS complex as faster heart rates and sometimes can mimic VT. So a patient on that might mimic VT, but in actual fact, is it widening of the QRS complex because of the fast heart rates. Propafenone, on the other hand, has a weak beta blocking effect, prolongation of the PR and QRS intervals with only a slight increase in the QT interval, so also not so significant, and also has negative inotropic effects. So flecainide available in oral and IV, propafenone in IV doses, usually given IV. So flecainide is usually the first line therapy for rhythm control in patients with atrial fibrillation in the absence of structural heart disease, such as established coronary artery disease. Used in supraventricular tachycardias mostly. Wolff Parkinson-White syndrome can be used. Ventricular arrhythmias is also used, and then particularly reserved for resistant arrhythmias, especially ventricular arrhythmias that are resistant to other medications. Flecainide tends to be successful. For propafenone, also first line for AF, also used in AF in pre-excitation, but is known to be more effective in ventricular than atrial arrhythmias. Okay. Flecainide has a very high risk for proarrhythmia. And again, CNS effects as listed: dizziness, tremor, blurred vision, abnormal taste, sensation, paresthesia, and can cause heart failure because of the negative inotropic effect and known to exacerbate heart failure in some individuals. So heart failure is sort of a relative contraindication, but in some cases it's a contraindication. Propafenone also exacerbates heart failure, causes bradycardia, and in some people who are known poor metabolizers, and that is a genetic mutation. So you have people who have poor metabolizers of propafenone. These people tend to develop bronchospasm if they are put on propafenone. The class 2, it's beta blockers, and we have an array of beta blockers: metoprolol, atenolol, propranolol, carvedilol, and esmolol. Propranolol was actually the first one that was developed, and use began in 1965. So these actually would block the beta-1 receptors in the heart and then in other organs. So generally reduce the sympathetic effect on the heart, and this, like I indicated, leads to decreased automaticity of the SA node and ectopic pacemakers. It prolongs the refractory period of these, that's the SO node and some of the ectopic pacemakers, and then slows the conduction across the AV node. So you have a slow sinus rate, prolonged AV conduction and refractoriness, inhibits automaticity, and blocks the cardiac sympathetic innervation and effects of circulating catechol amines. So other catechol amines are blocked and they are not so effective. Situation, we have oral and IV. Clinical use is several: atrial tachycardias, ventricular arrhythmias, arrhythmias associated with few chromocytoma, myocardial infarction, angina or hypertension. Adverse effect generally bradycardia, hypotension, fatigue, altered response to hypoglycemia, bronchospasm, sexual dysfunction, and all the beta blockade side effects that we know about. The class 3, that's a calcium channel blockers, and amiodarone, which is the commonest we know, blocks the rapidly activating inward rectifying potassium channels. So, like I indicated previously, phase 3 of the action potential, but it interacts with sodium channels, interacts with potassium channels, A-type calcium channels, as well as inhibition of alpha and beta receptors. So generally will prolong repolarization, prolongs repolarization, and has a reverse use dependence. So in this situation, the block or its effect is greater at slower heart rates compared to the use dependency or frequency dependency, use dependence of frequency dependency, which that's for the which works or effect is greater when the heart rates are faster. Okay, so for class 1A, it causes some membrane stability, alpha adrenergic blocking effect. Class 2 has beta-1 blockade. Class 4, calcium blockage, and then has vasodilatory effects because of its alpha and beta blocking effects, and in addition to its calcium channel blocking effects. So the other thing is that we have oral and IV formulations, and can be used or usually used in the atrial fibrillation with structural heart disease and heart failure. They also used in ventricular fibrillation, ventricular tachycardia, especially in patients who have an ICD to avoid frequent shocks when they tend to get these frequent shocks. So it comes in handy. Though looks like a general antiarrhythmic comes in handy in almost all situations. It tends to have a lot of side effects. Hypotension because of its beta effect, calcium blockage effect, and the vasodilatory effect. In addition, that is also related to the IV formulation. That's a solvent, polysorbates, ATM, benzyl alcohol, which are in its formulation, and these tend to cause hypotension. One of the reasons why it's widely distributed and causes a lot of these side effects is because of its lipophilic effect. It's very lipophilic, so accumulates in adipose tissue, cardiac, skeletal tissue, and preferentially in thyroid tissue, where it can cause hyperthyroidism or hypothyroidism. In high doses, can exacerbate ventricular arrhythmias, can cause bradycardia, heart failure in some situations, pulmonary fibrosis, photodermatitis, can cause tremors and peripheral neuropathy. Corneal deposits can occur, and hepatocellular necrosis. Ibutylite blocks the rapidly activating in-body rectifying potassium channels, but has not got the other effects of amiodarone, has not got those other effects. So the interaction with the sodium, L-type calcium channels, and the alpha and beta blockade, it hasn't got those effects. But that tends to also prolong phase 3 repolarization, and then it has some effect on the action potential duration and refractory period. The thing about the ibutylite, so I think so the thing about it is that it can cause QT interval prolongation, So that is something that has to be taken cognizance for, and then it may cause torsade, the point is, but generally using the acute conversion of atrial flutter or fibrillation and the maintenance of sinus rhythm. So the other one in this class is I think dofetilide, which has a black box warning, so has to be administered in hospital and under ECG monitoring to make sure that patients do not have a QT prolongation and it does not induce torsade. So this illustrates the action of the class 3 antiarrhythmics. So generally tends to affect this part of the membrane, that's the potassium efflux. So it tends to prolong the phase 3 of the action potential. The class 4, those are the calcium channel blockers, and generally we have verapamil and diltiazem. These block the L-type calcium channels, which leads to decreased calcium in the cells. So once calcium is decreased, there's decreased contractility, decreased rate of the heart, and it tends to, it's also known to prolong the action potential of the cardiac myocyte, but typically it's effective in the sinoatrial and atrioventricular nodes. That is where its action is usually strongest. So but then its major effects are more on the AV node than on the sinus node. So that is the main effect of the calcium channel blockers. So what it will do is that it will prolong the AV node conduction and refractoriness. So causes slowing of the sinus activity or pacemaker activity, and it reduces the automaticity. So these also have oral and intravenous formulations, commonly used in atrial arrhythmias, atrial fibrillation, re-entry supraventricular arrhythmias can also be used, but not effective in ventricular arrhythmias. So the verapamil, the thiazide are not usually effective in the ventricular arrhythmias. They also tend to have some quinidine-like effects, but generally they also have some anticholinergic effects. But mostly, or what is commonly known is hypotension due to depression of the contractility of the myocytes. So tend to have inotropic effects, and that can also cause some vasodilatory effects in the peripheral circulation. The other antiarrhythmics that we commonly encounter, and in some cases, some list them as class 5 antiarrhythmics, commonly is adenosine. So adenosine inhibits the cyclic AMP, and it does that by binding to adenosine A1 receptors. And this leads to opening of the potassium channel, so it causes hyperpolarization of the membrane, and mainly at the AV node, and it decreases conduction and the chronotropic effects. So adenosine mainly works in the AV node, and it's also known to also affect the sinus node to some degree. So what it does is that it blocks conduction through the AV node, blocks conduction completely through the AV node, but it's usually transient because it has a very short half-life. So that blockage resolves within seconds. It's usually in IV form, and commonly used AV nodal reentrant tachycardias and then AV reentrant tachycardias. The caveat here is that if it's a pre-excited atrial fibrillation, then you cannot use adenosine in these individuals. It's also used to diagnose narrow complex tachycardia. So if you are not sure whether it's an AV, NRT, or flutter, sometimes you can use adenosine to slow down, and then you can make that diagnosis. In addition, in some cases of automatic focal atrial tachycardia, you can use it. It's successful. And then there are individuals who have adenosine sensitivity, which originates from the RVOT. That can also be used successfully in those individuals. The side effects are usually flushing, dyspnea, and in some cases, chest pain. For people who have reactive airway disease, asthmatics, it can cause severe bronchoconstriction. So generally contraindicated in the asthmatics. So it can cause atrial fibrillation in some individuals or premature ventricular complexes, and sometimes can cause non-sustained ventricular tachycardia. So for bradyarrhythmias, two common medications we can use is atropine and isoprenaline. And these commonly will be used in sinus bradycardia and commonly will be after myocardial infarction or in the emergency situations, and sometimes during resuscitation. To maintain the heart rate, we can use isoprenaline to maintain the heart rate. But they have some additive effects, so combined usage should be done with caution. So I think I spoke about the use and reverse use dependence. So sodium, for the use dependence, like I mentioned, sodium channel blockage is greater at faster heart rates. And for the reverse use, potassium blockage is higher when the heart rates are at slower rates. Then the other thing about the antiarrhythmics is that they tend to have pro-arrhythmic action, even though they are anti-arrhythmics. Even though they are anti-arrhythmics, they tend to have pro-arrhythmic activity. And this is usually because of a re-entry phenomenon commonly. Because they tend to slow the heart rate down, what happens is that a re-entry mechanism can develop as a result of that. So once they slow the heart rate down, the propagation of the action potential slows. So there might be an area of tissue that can be depolarized or that can be excitable. And when that is available, we can easily have a re-entrant mechanism occurring. So this diagram sort of illustrates that. So the propagating wavefront is here, but because the heart rate has been slowed down, there's an excitable gap, and this can easily be excited, and there starts a re-entry phenomenon. So the pro-arrhythmic effects of these antiarrhythmics has been shown in some trials, and then the CAST, that's a cardiac arrhythmia suppression trial, used class 1 agents, encanite and flecainide, and patients with myocardial infarction. So what they showed was that there was increased mortality in these patients. But then the SALT trial was what provided evidence that pro-arrhythmic effects of class 3 agents was noted, and increased mortality in patients when sotalol was used. And they commonly caused polymorphic VT, that's Torsat. So that was sort of where the evidence was deduced. So use as prophylactics is usually not advised, especially with myocardial infarction. So there are various mechanisms that promote pro-arrhythmias. So in individuals with left ventricular hypertrophy, sotalol, flecainide, and propafenone can do that. Myocardial infarction, the sodium blocking medications can do that. Other structural heart diseases, sodium channel blockers can lead to arrhythmia. In heart failure, dronedarone is known to do that. Dofetilide is also known to do that. Then drug-drug interactions can also lead to or favor pro-arrhythmia. And then we have other factors. So being female sort of increases the risk. And it's said that testosterone regulates repolarization. So that might be the reason why females tend to have a pro-arrhythmic. Hypokalemia, hypomagnesemia can do that. And then other conditions. Antiarrhythmics generally are eliminated by the kidney or by the hepatic P450 system. So it will either go one of these pathways, and the percentage of what is metabolized by the kidneys or the liver can influence drug excretion. So the half-life of most antiarrhythmics increases in elderly patients and patients with renal failure. And these drugs, digoxin, disopyramide, dofetilide, flecainide, procainamide, increased in patients who have renal impairment. For patients with hepatic impairment, amiodarone, diltiazem, flecainide, lidocaine, metoprolol, propranolol, quinidine are increased. And then in congestive heart failure, amiodarone, flecainide, lidocaine, mexiletine, procainamide, and quinidine are increased. And then myocardial infarction, we have lidocaine, mexiletine, and disopyramide. So based on the age and the disease condition, the half-life of some of these medications, I mean, mainly renal, hepatic, congestive heart failure, and myocardial infarction lead to increased half-life of these medications. So in these patients, doses should be reduced and then ECG monitoring done. Amiodarone particularly undergoes extensive hepatic metabolism and mainly is excreted by biliary and has a long half-life from 25 to 110 days. So its effect might even persist or persist after the drug has been stopped. So some of them have short half-lives, but they have been modified in release preparations, and this sort of increases the half-life of these medications. So this table is busy, but I think that maybe we can take our time later and look at it. It gives us the bioavailability, protein binding, volume of distribution of these medications, metabolism, the half-life, elimination. So H is for hepatic, R is for renal. So we know the mechanism of its excretion or elimination, and then the active metabolites when it's degraded. So I'll skip this. It's quite busy. So this is a magnified form of that table. So this is easier to assimilate. So hepatic, renal, half-life, and then the active metabolites of the most common ones that we have. So amiodarone, we see 90% is hepatic. We see that sotalol 90% is excreted renally. Okay. So we'll look at, so let me skip this. Okay, so these are the effects and contraindications of these medications. So the main contraindication of some of the common antiarrhythmic medications are presented here. So disopyramide, heart failure with reduced ejection fraction, long QT. Flecainide, stated ischemic heart disease, severe left ventricular hypertrophy. That is a contraindication. And based on the ECG findings, you should discontinue the medication. Amiodarone, basically long QT. Once there's symptomatic bradycardia, QTC more than 500, you should be stopping. And then, depending on the systemic side effects too, that will also prompt you stopping the amiodarone. Dronidarone has quite a few. New York Heart Association class 3 to class 4, unstable heart failure, long QT, and then also symptomatic bradycardia. You should be stopping the medication. So this is also another table which looks at the cardiac effects, apart from the other effects. So class 1A typically can cause torsade. Disopyramide, we looked at it earlier, can cause congestive heart failure, has negative inotropic effects. Class 1C, ventricular tachycardia, we saw that. And then we saw the wide complex wide complex QRS for propafenone. For class 3, also, so we see that looks like torsade runs almost through all the antiarrhythmics. So apart from dronidarone, almost all of them, and then class 1C would have torsade as a main cardiac effect. And then the contraindications are also noted there. So, so this table was particularly busy, but we can take our time and go through it later. So I think I'm done with the pharmacology, and then so thank you so much.
Wow. Thank you so much, Dr. Windago, for that very detailed synopsis of the antiarrhythmic. You know, I willfully did not remind you of time, because this is a topic that we need to assimilate slowly, and I allowed you to take your time to explain it. Thank you so much. Thank you so much.
Thank you.
A few things I want to mention. There is one new medication that keeps featuring when you read about this antiarrhythmic, called vanacalant.
Yeah,
You can mention something about it.
Yes.
I think it's used for AFib. Yeah. Okay, then the other two things that I want to just contribute briefly. The class 1C medications, when they are used in AFib, sometimes, they can slow the heart rate and produce a one-to-one conduction and worsen, the heart rate. So then they're advised to be given with beta blockade, so something that blocks the AV node. And sometimes they can even organize the AFib into an atrial flutter. And then the other thing also that we've come across in some MCQ question, the specific, antiarrhythmic drugs that block accessory pathway. You mentioned them in passing, but it's good to take note of them, so the class 1A procainamide, the class 1C flecainide propafenone, and then the class 3, the butylide ofetilide. So those medications actually block accessory pathway, and they are the ones that are indicated when you have pre-excited AF. Now, before the latest guideline, amiodarone was amongst. Okay, it actually blocks accessory pathway. However, as you mentioned, amiodarone has pleiotropic effect. So it has an initial AV nodal blocking effect that actually takes effect even before the slowing down of conduction in the accessory pathway. So because of that, it can actually worsen, the pre-excited AF. So in the recent guidelines for supraventricular tachycardia, they have actually given amiodarone a class 3 indication. So that's something that we need to be aware of. Some older question, amiodarone would have been correct for, use in pre-excited AF. But based on recent evidence, recent guidelines, it's class 3 indication. So it's something things that we should note. If you can just, something about the vanacalant, I don't know, do you know the mechanism? Does it fit to any of this classification? I'm not sure.
Yes, so I came across it, but I didn't really pay attention to it.
Oh, okay.
So, yeah.
All right. So I'll open the floor to our colleagues. And if you have questions, suggestions, contribution, please, the floor is open. I'll just read some of the comments in the chat box. Olalekan is saying, thank you for this detailed presentation. Well done. Dr. Kalamama is saying, lovely presentation, a job well done. Dr. Baban said, fantastic, I enjoyed it. A lot of us were enjoying it. Dr. Itubi said, thank you so much, Awindago. Dr. Mohammed, excellent presentation. Chief Kweki is also saying excellent presentation. So you've done a very good job. Deji Stevens is saying great presentation. So thank you once again, Awindago.
Thank you.
Yeah, if we don't have, if we don't, someone about to speak.
There's a hand raised.
Oh, okay. Go ahead, please.
Okay. Thank you so much. Good evening, all. Thank you so much for the extensive presentation. Yes, I don't know whether you came across. There's a new classification, Von Williams classification 2018. Actually classified the anti-arrhythmic drugs. That's from classes 0 to class 7. Class 0 and talks about the HCM channel mediated pacemaker current blocker.
Yes.
Where they talk about the ivabradine, then the class 1, which are mainly the voltage and gated and sodium channel, class 1A, 1B, 1C. Then there's an additional class 1D, ranolazine. Yes. Then class 2 was further divided into class A, class 2A, 2B, 2C, 2D, 2E. It's a bit cumbersome, really. Then class 3. Then we have class 3A, 3B, 3C. Then the class 4, divided also further to class 4A to class 4E. Then class 5, talk about the mechanosensitive channel blockers. We talk about the majorly intracellular calcium. Their responsibility just for intracellular calcium signaling. And the example that was given on class 4 and 5 is the NP-amylcinamoxyl eternalic acid, said to be under investigation. Then class 6 talks about the gap junction channel blockers. Example is carfenozolone. Then also class 7, upstream target modulator. There they listed ACI inhibitor, ARB, omega-3 fatty acid, and then statins. I don't know whether you came across that.
Yes, I came across that, but like you indicated, that's a modernized classification of antiarrhythmic drugs, and like you indicated, quite complex. So I didn't really go into it. I'm not sure how it's caught up with clinical practice. Yes, but it's there. It's I think they've tried to define and add onto it, mainly because the Sicilian Gambit did not catch up with clinical practice. Yeah.
Okay, thank you so much.
Thank you.
Yeah, thank you very much, Dr. Olalekan. So please, if you can just share that classification in the group.
Okay.
Yeah, please, Dr. Kwiki, you have the floor.
Yeah, thank you so much, Dr. Conte and the presenter. I joined midway, but I think I really enjoyed the presentation because made an attempt to touch every aspect of antiarrhythmic medication. All of you will agree with me that this seems to be one of the most boring aspects of cardiology sometimes. And it can be very volatile. So thanks for a beautiful and detailed presentation. I just want to draw your attention to one of them that it's so important, and sometimes because of practice, and if you are in emergency care, it's a drug that you have to use, especially if it's available in your center. A drug like adenosine, it's something that is commonly used. I'm not sure how it's available in your center and some other places in the continent. But if you are handling cardiology emergency for a patient with SVT, it's something that you always come across. So it's important. Have you had experience with use of adenosine? Just to discuss some practical experience. Okay, can you just throw a summary on experience with it?
Yes, so I think quite a few. Mostly was one supraventricular tachycardia. We're not sure if it was an AVNRT or atrial flutter, but we used it, and then it slowed the rate down, and then we realized it was an atrial flutter.
Great.
So initial first 6 milligram was given IV, and then we followed up with another 12 milligram before it slowed it down, and then we saw it. Second individual also a patient on one of the hematologic malignancies who came in with a supraventricular tachycardia. He was unstable, not so unstable, but BPs were low, but conscious. We used the adenosine, and then that's converted it to a sinus rhythm. Yeah, so I think I've used it twice. Yeah.
So can you just a bit explain how you give it?
Yes. So generally, yes. So generally, you need to for the contraindication. So usually asthmatics can cause bronchoconstriction. So best you avoid it. Also, patients who have been on caffeine in the last 30 minutes to an hour, it won't work because the methyl-xanthines would block its effect, sort of. So what you do, you get a large bore cannula. So usually a central line is best, but if you don't have a large bore cannula, and then an IV. So once you give it, so you need to give it rapidly because the half-life is very short. That just is 6 to 10 seconds, others 10 to 30 seconds. So it has to be given rapidly, and then you flash with normal saline rapidly. And then for what I've seen done is that you lift up the arm so that if it's given in the arm so that it flows faster. And you should also have ECG monitoring, so there should be telemetry, so you are monitoring the heart rate. And once you give it, patients would usually have some sensation, usually a warm feeling in the chest or some uneasiness. The 2 patients we gave, they had that, a warm feeling in the chest. And then what you notice is that there's what looks like an asystole, and then the heart rhythm starts again for the one that worked, and then there was a sinus. The other one just slowed it down, and then we're able to see the ECG leads carefully. So that was how we gave it.
Yeah. So so ideally, while you connect your cardiac monitor, you should be able to print out the reading at that time where you revert back to either a sinus rhythm or the underlying arrhythmias. So if you have an assistant that just be able to print out a registry while it goes back to the underlying arrhythmia or sinus rhythm for you to be able to record it properly. The other thing again is that you need to explain to the patient ahead of time of that feeling. So you need to tell them before you start giving the patient the medication so that they will expect it before it comes, so that they don't go into cardiac arrest because of the feeling, because of that initial feeling. Then you flush with 10 ml of normal saline. So it's important, not just normal saline, up to 10 ml of normal saline. The idea is able to deliver the adenosine directly into the vein. Ideally, it should be done through central vein, where it can get into the circulation directly. But of course, most of the time in the ward or in emergency, you have access to a central vein. So yeah, so that's really how you do that, and it's quite handy. I'm happy you talk about the contraindication and keep that in mind. Then just to also talk about other one, things like sotalol. Sotalol, we know that is in class 3, even though it has beta blocking property. So if you are giving any patient sotalol, you have to monitor that patient and also educate the patient, because sotalol is one of the medication that cause prolonged QTC. So if you just keep patient on sotalol for a long time without a plan to monitor the patient, follow up, and the patient develop QTC, cardiac arrest, you may as well be liable for that. So you need to educate the patient, discuss the side effects. Sometimes it has to be an agreement between you and the patient. And if the patient doesn't want to take it, you can look for alternative. That is, patient should be involved in the decision and should be told the potential side effects. Of course, they're usually not the first line, so you may have exhausted possibilities before you thought of sotalol. Then the concept of amiodarone is something we use every time, but it's not without the side effects. Remember, the amiodarone induces hypothyroidism, in which case, if it happens, you continue with your amiodarone and replace the thyroxine. But if the patient comes with amiodarone-induced thyrotoxicosis, it could be type 1 or type 2. Type 1, as a result of too much of iodine component in amiodarone, so they tend to produce a lot of thyroxine. Then you just give your carbimazole for the treatment. Or type 2, you give steroid. But this on the background of, could you stop it? So if for whatever reason you can stop it, you look for alternative. Don't forget the side effects of pulmonary fibrosis and all that. So usually where I am, when you want to give some of these medications because of legal issues, there are things you need to discuss with the patient extensively and documented clearly on the note of the patient. And patient need to be followed up with chest X-ray, thyroid function test, and the likes, such that patient can be monitored. Sometimes we would give them for a short time. For instance, if the reason we're giving them amiodarone is atrial fibrillation, for instance, we rather want to give it for a short time, say 3 months, and then within these 3 months, we can work up the patient for cardioversion. So we tend to avoid being on amiodarone for a lifetime because of the potential complication. So it's good to keep these in mind. Don't forget flecainide. Flecainide is another fantastic medication, but we also know that in the context of structural heart disease, is not a good medication. So keep that in mind. So overall, it's a fantastic medication. I'm aware that there's no way you can have all the medication handy. It's never available all over the world. But the ones that are commonly used in clinical practice, it is reasonable for us to have them handy. Thank you so much.
Thank you so much. Thank you.
Thank you very much, Chief Kweki. I think we have Dr. Orimolade in the call. If you have any comments to make, Dr. Orimolade.
Thank